Fantastic. Okay, here we go.
Thank you.
Yes, so I'm delighted to have so many people in the call, and especially to hear that most of you are new to this concept. And this is, I first had in my career a kind of a wow moment with the ultrasound and, the window to the womb and how I could do amazing things in the fetal medicine field. And then I had the second wow in my career with the CTG, and how suddenly I understood what the fetus was telling me. And this made a huge difference for me and for the people that work with me. And that's why I'm so passionate, because you won't be the same after today. So, very quickly, just to tell you, I work in London. We do physiological CTG here. We also saw a decrease in hypoxic ischemic encephalopathy, and we stopped doing FBS. And this was back in 2016. So we have not done one FBS since 2016. I collaborate with Neoventa and I do teaching nowadays a lot, and that's part of my kind of a declarations of interest. So I was asked to talk about types of hypoxia, and I'm going to try to make it in a nutshell, as simple as I can, so you have a good understanding of what are the things we call and how we left the normal suspicious pathological that we don't use anymore, and we just talk about types of hypoxia. Types of hypoxia is understanding on the CTG what is the fetal response to the hypoxic stress, and basically, for how long is that hypoxic stress taking place and how intense it is, the baby will show different things, will react in different ways because it will compensate in different ways. So we have 4 types of hypoxia. So the ones that you see in labor are the gradually evolving hypoxia, the one that evolves slowly during the hours of labor. And that is the most common. That's why I put it a big arrow. Sorry, my pointer doesn't seem to be working, but it's, the second one. Then you have the ones that are more intense and quicker. And in the extreme, you have the acute hypoxia, and then you have in between the subacute hypoxia. And of course, if the hypoxic stress is from the antenatal period, it has been going on for a longer period, even if it's of low intensity, that are the ones that we should recognize before or at the start of labor. And just bringing what the previous speaker told you about, when we look at the CTG, we think that we are looking at the heart, and it's the heartbeat that we are listening. But we can't forget that the heartbeat is changed by the nervous system and is changed by the adrenaline, noradrenaline, so the catecholamines. So in a way, although we are listening to the heart, the CTG can be really a neurological examination of the fetus. So how stable is the baseline? It's a measure of the heart, of the pump. The variability and all the things that you've learned about the sympathetic and the parasympathetic and that kind of a communication fight between the two, that's what gives it the variability. Though this variability is very much a measure of the brain. And then you have the adrenals that with the catecholamines will make the heart rate go up when it's needed, when there's further stress. And then you have the decelerations mediated by baro and chemoreceptors. So one of the big mistakes we have done in the past was to compare the hypoxic stress of the outside of the womb life to the that outside you have lots of oxygen, and inside the womb you are in a bubble of amniotic fluid. So if we are having an hypoxic stress and let's say an exercise, if we need more oxygen, we just breathe deeper and we breathe faster. We increase our respiratory rate. But inside the womb, the baby cannot use the lungs to do that. So the mechanism that has is to decrease the workload. In both situations, what we want is to keep the energy balance of the heart positive, a safe heart, so that can, even if momentarily needs to decrease the heart rate, decelerations are a way to protect the heart. So they are not bad. They are a compensation mechanism. And you can almost pair them with the RESPs, the respiratory rate in adult life. So when we look at decelerations, there's been so much said about them. And there's also so much said that actually there's no predicted value in counting, naming, shaming decelerations. There's been lots of papers to say there's no correlation between the decelerations and how the baby comes out. And unfortunately, it's exactly what over the years we have been focusing our attention to, because our guidelines have been asking us to count them, to classify them, to look relationships with contractions and all the other things. So our focus has been on the wrong thing. So what I'm going to ask you now is not to look at decelerations, it's almost to forget them, is to delete the decelerations and to look in between the decelerations. And it is in between the decelerations that you will be having the answer from the baby if the baby is well, if it's in a compensated or decompensated stage. So a very important message is that if you have a stable baseline, stable heart, and normal variability, intact brain, and the baby is spending more time at the baseline than decelerating, you can be reassured that the central organs, the brain and the heart, are well oxygenated. So you don't need FBSs. So the previous speaker did cover a little bit about, the gradually evolving hypoxia. So this is the most common one in labor, because labor is a stressful event. And stress comes always with decelerations, because that's the response that the baby has to the increased need of oxygen or the intermittent stop of supply of blood flow. As the hypoxic stress continues, there will be loss of accelerations, so quietness, so not expending energy in things that are not necessary. And if it needs more, it will get more by releasing adrenaline, by releasing catecholamines. And that will take an increase in the heart rate, asking more from the placenta, peripheral vasoconstriction that you won't see on the CTG, but you know that is happening, and glycogenolysis, which is also another thing that will be happening. And some of you have asked, this is exactly what STAN, for instance, looks at, is the breakdown of glucose when there is no oxygen at the heart level. All this is a compensation stage. Now, if we get to the decompensation, then you have first the brain, abnormal variability. It can be either reduced or increased. And then finally, when the heart cannot cope anymore, you have an unstable baseline. So the baseline is not steady. It means that the heart is failing. And the final thing is a terminal bradycardia. So I always like to compare it with the runners. And if you are in the beginning of this journey with very mild hypoxic stress, almost a jog in the park, what you have is that you start having decelerations. And this is the top CTG. So the same baseline, beautiful variability, and the decelerations will come. As you are through your marathon, then you are not chatting anymore. You don't have energy to chat, to talk. So that is when the accelerations disappear. Decelerations. Is this baby unwell? No, it's not unwell. Would you stop a marathon runner mid-race when they are tachycardic, tachypneic, just enjoying the run, sweaty, but feeling good? No, there's no point in doing cesarean sections at this point. And as you see, if you take a look carefully, from the first CTG to the second, the first one shows a heart rate of 120, and the second one shows a heart rate of 140. So there has been an increase in the heart rate. It's still within the normal, but it's not what is the usual for that baby. So there's been a change. It means that we are in a compensated stage where there has been already release of catecholamines. As the stress continues, you'll get to a point where if you are a healthy fetus, or you can push your heart rate really high. It can be 160, 160, 180. But as far as the variability is normal and you have more time spent at the baseline, well, of course, you need to look at the overall picture. This is usually achieved at a time where we are to finish the line. You can't have this level of stress if you are only 3 or 4 centimeters. So, and I really enjoy the previous talk, take the overall picture. With my trainees and my team, I used to say in the beginning, I've changed from having a photo album to watching a movie. You can't just look at one snapshot. You need to unfold the CTG from the beginning to know what was the normal baseline at the beginning and understand the changes through time. Of course, what you don't want is to get to the stage where the variability is gone, so the heart is already hibernating, and you are risking hypoxic ischemic encephalopathy, and you don't want a heart to be failing, which is this reduced, unstable baseline. We call it step ladder to death. And believe it or not, in the past, we have seen this, a baby just quitting in front of our eyes. So does this work? Is this safe? Yes, it is safe. Because we are all human. So we all respond to stress the same way. We start our respiratory rate, babies will start decelerating, then we become tachycardic, and only at the end we become dizzy. So loss of viability, and finally collapsed. So it's, and I brought this paper that I especially like from Edwin's group, where they looked at 500 cases, and as far as the variability was normal, and there was time at the baseline, irrespective of if there was tachycardia or not, they have not seen an increase in admission to the neonatal unit or low APGARs at 5 minutes. So this is basically the long run, the gradually evolving hypoxia, the stress that comes through the hours of labor. So this second one and the big arrow, because it's the most common. But what I want now to look at, what about the other two? And let's jump now to the acute hypoxia, to the extreme. So acute hypoxia is the thing that no one misses. And in the UK, there will be lots of buzzers and rings and people running around. So acute hypoxia is that when there's such an intense hypoxic stress, there's such a quick and interruption of blood flow, that the only way that the baby has to protect the heart is just to drop it and just to be very slow. And from animal studies where they actually clamp the cord, we know that in those extreme situations, the pH is dropping 0.01 per minute. If you want in a simple way, 0.1 every 10 minutes. So we should do something, yeah? And that's no doubt that people really don't miss this one. But the question is not what it is why is it happening? Why would suddenly the blood be interrupted in such intense and strong way? And you can think of it from the maternal side, at the placental level, or at the cord level. It can be on the maternal side that mom had a collapse, had a pulmonary embolism and just had a collapse, stopped breathing, asthma attack, whatever you want to call it. Or it could be just that had an epidural and got very hypotensive, so less perfusion to the placenta. It could be at the placental level, where you either have an abruption, so the placenta separates from the uterus, or you have such a strong contraction that stops the inflow of fresh blood from the mom. Or you have it at the cord level, either cord prolapse or cord compression. And you wouldn't dream to treat such different scenarios in the same way. And that's why the first thing to do is to divide them into things that we can correct and we call reversible causes, or the things that we can't correct. And if you can't sort it out, the best thing is just to deliver as quicker and safer as you can. But if you look at these two groups, the ones that are more severe are at the same time the ones that are a lot less common, are the rarities. And so many times I've seen people rushing to do a big surgery to a baby that is just fine and that we could just correct. And there's no benefits at all of doing cesarean sections, even if you have a prolonged deceleration, if it's a reversible cause. So if we take this by steps, so step one would be make sure that you are excluding the irreversible causes. Because if you have an abruption, a cord prolapse, a scar rupture, just please deliver as quick as you can. Speak with your anesthetist, because these are the ones that will need a GA cesarean section, a general anesthetic, to be quick. But the anesthetist can be also the ones causing the problem. When is the anesthetist causing the problem? When they do spinals and epidurals, of course, because they take the pain away, but at the same time, they produce this venous vasodilatation. So the blood goes to the legs, and suddenly the mum has very low blood pressure. So the perfusion to the uterus is compromised. And what the baby does is prolonged deceleration, reducing the heart rate. So in these situations, if you have a maternal hypotension because you did an epidural, because you have a tonic contraction because you overdone the oxytocin, or if you have a cord compression that is just because of position, you just sorted it out. You stop the oxytocin. If necessary, you even give a tocolytic, either terbutaline or salbutamol. If it's maternal hypotension, put on left lateral and squeeze the fluids. And by changing the position, you'll be also addressing any cord compression that may be causing it. Now, with physiological CTG, there's another thing that is very important. The CTG will tell you the tips to understand if the baby is going to recover or not recover. It will give you the tips to know, shall I go to the theater now or shall I wait in the room? And this is basically the variability before the deceleration and the variability in the first 3 minutes of the deceleration. Let me give you 2 examples. If you look at these 2 CTGs, you can see that the one on the left, you have normal variability before the deceleration, and you have variability maintained even during the 3 first minutes of the deceleration. The one on the right side, the variability is already kind of a bit reduced before, but it's definitely pencil tip in the first 3 minutes. So if you have reduced variability before, and especially in the first 3 minutes of the deceleration, please don't waste time. Take to theater, and then you can reassess there. Because when you have this reduced variability, you are more likely to be in a situation where it will not recover. And as you can imagine, which one is going to recover, the left or the right? It's going to be the left, isn't it? So the left one, and you can see the cause. The CTG is giving you all the information. You can see the amount of uterine activity that is going on that trace. So too much oxytocin. So the action was to stop the oxytocin and just give terbutaline if it was not enough. The one on the right was a cord prolapse. So there was, you don't have more CTG because the diagnosis was done in the first 3 minutes. The first 3 minutes is the time to diagnose and exclude the irreversible causes. And then we have this rule of thumb. It's very much human factors driven, so you don't lose track of time. So first 3 minutes, just recognize and exclude your irreversible causes. If that's the case, just proceed to deliver. In the first 6 minutes, you should be putting in place the actions to reverse what is reversible: hypotension, cord compression, tonic contraction, and by 9 minutes, 95% will have recovered. If you don't see recover, then you need to move anyway, because you need always to think, am I missing something here? Is this a concealed abruption? But I tell you, I've never seen a case where the variability is normal in the first 3 minutes that have not recovered. So this was acute hypoxia, and now subacute hypoxia, which is something in between. Subacute hypoxia is very easy. Is really easy. Subacute hypoxia is a baby that spends more time decelerating than at the baseline. And it is actually something that tends to be dismissed. And because when do you think that this type of hypoxia is more common? I'm giving you a couple of seconds so you can kind of come to your own answers. It's, of course, the active second stage when the woman is pushing, because there's only 2 causes for subacute hypoxia. Is too much contractions, either by active pushing or oxytocin. Is usually one of 2 things. So it's very easy to revert. Is either stop pushing or stop oxytocin. And because it's very typical of the second stage, people tend to be sometimes a little bit blind to it. Oh, this is a second stage trace. Oh, this is a suboptimal CTG. No, please. Because remember, the pH is also dropping. The equivalent of an acute hypoxia in 10 minutes will happen to this baby in 20 to 30 minutes. And you may have someone pushing for an hour. So this is something that is especially important for the midwives. For the obstetricians also, but because you do so many more deliveries than we do, and because you are always with the patient. So don't call it second stage CTG. This is very much a subacute hypoxia, because if you were to do the same exercise and just blind the decelerations, and you see that the time spent at the baseline is very little. And not only that, the variability that was kind of within the normal before quickly turns into abnormal. And if you look carefully, not only you have periods of reduced variability, you have mostly periods of increased variability. This is what we call the zigzag pattern. It's a sign of autonomic system instability. And a paper from the Spanish group, Ana Garcia looked with Edwin about this pattern in the second stage and how much it is correlated with low APGARs and low pH, even if it was seen for short periods like 2 or 3 minutes. So if you have this zigzag pattern, please stop the pushing and reassess, or stop the oxytocin and reassess. And most of the times you see the baby nicely recovering to a normal variability. So this is what I had to tell you. This gradually evolving hypoxia, subacute hypoxia, acute hypoxia are the intrapartum types of hypoxia. But I couldn't finish without highlighting to you that you can only apply these rules for the babies that start well. Because what if you come to the start of labor you are already tachycardic? What if you start labor and your variability is already reduced? What if you start labor and your baseline is not steady, or you have shallow decels? It's, if you are a marathon runner, is to ask how to know you are too sick to run. The baby fit for labor. And this is a piece of work that I have been working very hard, because this is one of the misdiagnoses. Babies that start unwell will respond. So we came about with this checklist to help the teams to identify in the antenatal period or in early labor the babies that shouldn't be really putting through the stress of labor, because they will not be able to cope. And because what they will show on the CTG is nothing like these athletes. Because how can they push the heart rate up if they are already tachycardic? How can you run if you have a fever, if you have infection? So this is how can you run if you have anemia? So this is how we exclude that. And very interestingly, the animal studies, they show that for babies that have chronic hypoxia, it will impact on cardiovascular defense and how to react to the stresses of labor. So it means that they will not follow the book. So these are the ones, the CTG was not that bad, and suddenly the baby died, intrapartum stillbirth or HIE. That's because you won't see big decelerations. With physiological CTG, you will learn to love decelerations. Decelerations, it means a baby with ability to respond. It means that they will go by the book and that you can be their safekeeper. So important message and final message, apply the CTG checklist at the beginning to exclude chronic hypoxia and or other antenatal injuries, so you identify the ones that are not fit for labor. And this is what we cover. So chronic hypoxia, gradually evolving hypoxia, the subacute, less time at the baseline, and the acute hypoxia, where I've asked you to look at the variability before and during the deceleration. And remember that, reality and our labor wards, this doesn't come in boxes. So you can have a baby that starts with a gradually evolving hypoxia and then has an epidural and has an acute hypoxia event, or has a gradually evolving hypoxia and then you start Syncto and you go through a period of subacute hypoxia. And then all the other things that go around, and having that perspective that I so much enjoyed listening from the previous speaker is fundamental, putting the thing in context. What about labor? What are the things that interfere? And I'm sure that this will be covered through these 2 days. I'm sorry this was a bit rushed. I hope that the interpreters could cope with me, my English, my accent, and the speed of I talk. The guideline is you can download with the types of hypoxia and the management of each type of hypoxia through the physiological CTG link. And I've also put together a physiological CTG in 3 easy steps to help people to apply this in real life on labor ward. So feel free to Google and watch if you have the time and the interest. Thank you so much. I'm going to stop sharing so I can see someone. It's always a bit daunting to be speaking to a screen. I wonder if you are still there.
Perdón. Muchas gracias, Susana, por tu excelentísima presentación, muy clara, muy concisa y que creo que nos ha podido dejar claro, o por lo menos empezar a tener claro cuáles son los tipos de hipoxia, las causas y un poco nos has avanzado ya también las soluciones. No sé si Berta